Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
I'm starting, right? Welcome back to the Dusty Muffins.
Welcome to this week's shit show.
Something happened this week. Well, now it's been last week, I suppose, at the time of this recording. And we've all been talking about it. Social media has been blowing it up. And it is the name change of PCOS, Polycystic Ovarian Syndrome, has been officially retired. Not by a social media campaign or a podcast, interestingly, but by Lancet. So a paper just came out. It was a global consortium of 56 leading academic, clinical, and patient organizations by 14,000 survey respondents across every region of the world. And on May 20th, 2026, it has a new name. It is a mouthful, but it is a new name. Polyendocrine Metabolic Ovarian Syndrome, or PMOS, or PMOS. I don't know, girls. PMOS? PMOS? PMOS.
Depends on where you live.
PMOS, maybe?
Yes. PMOS. So we're going to talk about that today.
Yeah, so we're going to break down exactly what this name change means. If we can figure out what it actually will do for the world, that'll be even better. Why it happened, what it got wrong before, and what it means for you if you're living with this diagnosis.
We know the name change doesn't sound like the most exciting headline, but stay with us because this one is a big deal. It's not a rebrand, it's a reframe of what this condition actually is. It's not perfect, but it's an improvement on the last 95 years of calling it Polycystic Ovarian Syndrome. And giving something a better name has real consequences for how it gets diagnosed, treated, and taken seriously.
Yeah. And it's not, we've used this forever, right? PCOS is a term that I've used my whole clinical career, and I'm sure both of you have as well. And so when we always thought about that, we always thought it was the classic, right? There's cysts on the ovaries. And if you don't have those, then you don't have PCOS, right? And that's just never was the full picture. Because now how many women, as they're starting to understand their hormones, their bodies, their insulin resistant, come to you and say, I think I have PCOS, but I know I don't have cysts on my ovaries.
Right.
Yeah.
Right. Because that's only 30% of women will actually have the ovarian component. And you remember the old clinical diagnosis of how we used to diagnose was you had the Rotterdam criteria, and you had to meet 2 of the 3 conditions: irregular absence periods, high levels of androgens, so testosterone with symptoms like acne or facial hair, but like that testosterone over 45, which we love to see now in menopause, and then polycystic ovaries. And then at some point, and I don't know when it changed, it used to be the ratio of LH to FSH, when LH was twice FSH, but that got dropped somewhere in the Rotterdam criteria along the way.
Let's talk a little bit about the cysts too, like Aoife, right? So I think when you say that, like cysts on the ovaries, I think a lot of people, and probably clinicians too, don't they think like cysts are bad, right? Like those are not good. They cause pain. They can be big. Are they hemorrhagic cysts? Are they normal cysts?
Yeah, I mean, everything about this was mishandled right from
Yeah.
the beginning 100 years ago, right? Because they're not cysts. Cysts are fluid-filled structures. And what these are little follicles. Like normally every month you might bring 10, 20 follicles to the surface of the ovary. And so each of those have an egg inside them. And over the course of a couple of weeks, they will mature and one will fully mature, rupture, and that egg will be released. And that's why we can get pregnant. So these are not cysts. They're follicles that have not matured. And often the problem in originally PCOS was that none of them matured. And they all just sat there and none of them ruptured. And we weren't able to get pregnant because things were so irregular.
Have you been told your labs are normal, but yet you still feel exhausted, foggy, and gain weight simply by looking at a meal? Well, you're in good company. In midlife, normal isn't enough. You deserve to feel like yourself again. I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and certified menopause specialist. I deep dive into the areas often overlooked: hormone optimization, thyroid health, gut health, medical weight loss, including administering testosterone therapy for women. No rushing, no insurance hoops, just a blueprint back to a vibrant life. I'm accepting new patients in Virginia, Florida, and 5 other states. Book your clarity call at www.christinehartkressdmp.com.
So yeah, such a misnomer. And what a way to like kick the can down the road. To call something that has all these metabolic effects all over your body, affects every cell in your system, and boil it down to cysts on the ovary. Right. Like you don't even get it right. They're not cysts.
Right.
But
And
boil it down to follicles on the ovary. Like what a way to just say, well, endocrinologists aren't going to manage this. You know, nobody's going to manage this. It's an ovary, so let the OBGYN or the internal med or the family doc manage this.
Yeah. And if you don't have the cyst, then you must not have it. Right. So then, all of these women who are experiencing infertility or, hirsutism or hair on the face, and other insulin resistance, other types of clinical indications of PCOS, now PMOS, they were, gaslit, or they, were just told, well, it's not PCOS because your ovaries look just fine.
And you start off learning about this, learning those criteria, and you have to have those cysts on the ovaries. And then as you go through your training and you go through your career, you learn like, no, you don't really need those for diagnosis, because a lot of women with PCOS don't have any cysts on their ovaries.
Right.
And then you're like, wait a second, wasn't the whole thing based on you having cysts on the ovaries?
And even some don't have problems getting pregnant because they find out later they had PCOS, but they didn't, but they could get pregnant. So it just is all.
It's a spectrum, isn't it? Mm-hmm. It's a spectrum. Some women have it very severely. They have every single symptom you could possibly get. And like others menopause. Have 2 or 3.
Right. But most of the true PCOSs, are anovulatory because, PCOS was, always a, diagnosis of low progesterone, which is why so many women, when you give them the Provera withdrawal and infertility to get the cycle starting, a lot of people will ovulate and then go on to get pregnant. So, that part is, interesting as well for women. And, we used to just manage it by putting you on birth control pills and shutting down the ovaries. Would be the classic way we used to manage it. But then you fail to look at the rest of the rest of the syndrome. And I think, someone was talking about on social media, like this is very much, an endocrine and metabolic disorder. We see insulin resistance. And, for men, they don't call it, someone had phrased it something about something testicular disorder. It's just metabolic syndrome. Those paunchy, bald men, have insulin resistance. It's metabolic syndrome. But women, it's polycystic ovarian syndrome. Like it's not treated in the same way, although it is the same physiology with the insulin resistance. And that's really where it stems from in, for both genders, right? And so I think that's, interesting, and treatment winds up being the same.
Yeah, and I think we have classified women as either PCOS or metabolic syndrome, or PCOS, and then they also have metabolic syndrome, but it probably is just one.
Right. It is
right?
metabolic syndrome.
Right? It's metabolic syndrome, period.
Yes, which involves the ovaries. That's what it should be called, really.
Yep.
Yeah.
And do you think the main reason for the birth control was because of the anovulatory cycles and the risk then, of having anovulatory cycles?
Well, I think, yes. But I think a lot of it, when we were putting people on continuous birth control pills, is because when the ovaries do have multiple follicles sitting in there, women do tend to have pelvic pain. So if we just shut them down, then you're not having all of those, follicles that aren't maturing. So, I mean, that's why we used to, in GYN, we used to put people on birth control pills. I mean, you give them maybe some spironolactone for the facial hair, because we know there's high androgens with it. And we give them birth control pills and sort of send them on their merry, merry way. And then you weren't worried about irregular cycles. You just weren't having them anymore. I mean, Aoife, you've been, you're in the 30-year crunch with me. I mean, did you see anything differently with treatment, like way back when?
No. And like the biggest thing to happen in PCOS in my career was using metformin, finally coming around to...
They were all on birth control, and then, metformin.
Yeah, to adding in the metformin to the birth control, which did change a lot of women's lives and even helped with reproductive capacity,
And I think where it's interesting, right, is that people assume like insulin resistance is just about heavy people, that only heavy people are insulin resistant. And then, it does impact 85% of people, including I think this is fascinating, 75% of lean women who have a completely normal BMI have insulin resistance. And, when we're talking about long-term longevity and health, when they are insulin resistant, we have elevated cardiovascular risk. We have hemoglobin A1Cs that are creeping into the prediabetes, dyslipidemia, hypertension, and fatty liver disease as well. And so, none of that was in the original name. And, yes, we do have women who have the visceral fat because, they can't use their sugars for energy and they store it for fat, and the pancreas produces insulin. And then over time, the pancreas peters out. And that's when you're not producing, even adequate insulin. And then diabetes, sets in. And so, the metabolic picture can get missed for years, even decades. And then in menopause, without the estrogen, we see those climbs in, pre-diabetes. We see the cholesterol changes, but could we have noticed them way back when we were looking for ovaries?
Yeah.
Yeah. So it's a whole mess.
What I didn't realize was, when I was reading a little bit about the insulin resistance, I hadn't realized that the high insulin levels could actually stimulate the ovaries to produce more testosterone. That was news to me. And reduces liver production of sex hormone binding globulin. So all of that. Yeah. For our listeners, the sex hormone binding globulin is a protein in the blood that binds a lot of our testosterone. And so if you have less sex hormone binding globulin, you're going to have more free testosterone, which is active, which is why you can get a lot of that extra hair growth, etc.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, see-me, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Yeah, the functional medicine community, that's a key to insulin resistance, is looking at that sex hormone binding globulin. If it's below 70, keep looking. You probably have insulin resistance. Very much correlated. Yeah.
And we talked a few times about metabolic syndrome as well. So just to let people know what that is, it's usually like a collection of 5 things. And I think we can diagnose it if we have 3 of the 5. So it's elevated blood pressure, elevated blood glucose, low HDL. I always tell my patients the H is for healthy and the LDL, the L is for lousy. And high triglycerides, which is another type of cholesterol, and then a waist circumference, elevated waist circumference, so which is that visceral fat around the middle section. So that fat on our arms and our legs and our bottom, you know, that is not dangerous fat, but that fat that we gather around the middle, that's really dangerous.
Right. When that ratio is more than 0.8. I learned recently too about the, I was looking at the HDL to triglyceride ratio greater than 3.7 is another marker of insulin resistance, and not one that we're taught.
No, I do a HOMA IR on everybody now. So that's an insulin resistance score. So you get a fasting glucose. So usually we're checking like a basal metabolic panel or a complete metabolic panel. And then you just add on an insulin level and you do those fasting when you're having any other blood tests. And then you can put them into a calculation to come up with that insulin resistance score. Less than 1 is normal. 1 to 2 is definitely showing signs of becoming insulin resistant, and then more than 2 is insulin resistant. Mine is over 4.
Yeah. It makes weight loss like a challenge, and especially when you're talking about increased inflammation and with decreased estrogen.
Yeah.
And you know, I just saw a patient today, and you know, she'd been struggling doing all the right things and was perplexed. Well, you know, her fasting insulin was elevated, her hemoglobin A1C, her HOMA IR score is about a 3.5. And, you know, we've got to address that root cause, and then, you know, her weight will start coming off. But, you know, she said that people had always looked at her metabolic panel and told her, you know, the classic, it is normal. It all looks normal.
I know. And you know, your A1C that they tell us to test and your fasting glucose that they tell us to test, often normal, because the fasting glucose is usually the last bit of control you lose over your blood glucose. It's the control over your postprandial glucose after eating that you lose first. So really, so much of what we're taught is absolute shite. And you know, we're only discovering it now. We're watching the wrong things, we're doing the wrong things, and we're missing all of these issues that could be fixed. We should talk just for a minute on, I'm sure there's a lot of people listening now who'd be like, okay, so if I have insulin resistance, how can I get rid of it?
Yeah, I'm a big advocate of getting those glucose monitors, which is in fact the way I started to understand that my postprandial glucose was going off the charts when I started going through the perimenopause transition, because not my A1C nor my fasting glucose was off, but postprandially it was insane after I would eat something, you know, even fruit that I thought was healthy. So I think that's one big tool that you now really can get off Amazon at a pretty decent price for patients. It gives you so much data on what your body is doing in real time. So I definitely like my patients to use that, even, you know, just to kind of see like what's happening. What is it? You know, are you going low? Are you going high? I
love it, Rebecca. I tell so many of my patients about it if I suspect they're insulin resistant. Dexcom, who make all the insulin products for people who have diabetes, they also make one for a continuous glucose monitor for people who don't have diabetes. So it doesn't have alarms going off all the time. And it's called Stelo, Stelo. And for $100, this is not a sponsored mention, but it's just the one that I tell my patients about. $100, you get like a month worth. You get 2 sensors. They each last for 2 weeks. So you get a month's worth of data. It is so worth it, because people think they're eating well, you know, and then they see, oh my God, my sugar shot up. Oh my God, I had a really good one the other day. My patient said she ate, what was it? A turkey sandwich, I think. And her blood sugar just shot through the roof. And then she had lunch and she had a big slice of red velvet cake. And she was scared to look at her numbers afterwards to see what would happen. And nothing happened. She didn't get a big spike. And it was because she'd had this cake, which was filled with sugar, with a meal. which had protein and fat in it.
Yeah.
And so she
Is that what she
learned,
ate first and then ate the cake second?
yes.
Yeah.
And so when it just teaches you how to be smart, right? It's not that you have to cut things out, but if you love to have that, I don't know, let's choose something healthy, like that banana every day, but it makes your banana go, or it makes your blood sugar go sky high, then try it with a few almonds or a few walnuts or something and just see what a difference that makes, you know?
Makes a big difference. Even when you're fasting and before you work out, you know, I'm one of those that my blood sugar will spike during a workout. And so oftentimes if you have just, you know, either a little bit of protein or some fat, like some almonds or walnuts before you work out, then it does the same thing. It's crazy.
Yeah. It's called glycemic index.
Yep.
Yeah, I think, you know, I think it's so important for women to realize that the things that they did even before perimenopause and menopause that were working for them, now when you add the, you know, the hormone dysregulation, you know, your hormones all over the place or not at all, or we're trying to get them optimized, that the foods that you're used to having, you know, maybe, like you said, really good, healthy choices. But even now, when you add the hormone component to that, your body just can't tolerate it. And I think it provides so much good data because you get to make a decision. Is this spike in my blood sugar? Because every time you spike your blood sugar, you're going to store fat. Is that spike worth it? I mean, I was a little sad to see that for myself. I could not eat pasta anymore, but I was really happy that red wine does nothing for my blood sugar. So it was like a good balance. But like, you know, I put it on my husband. And I mean, it's only good. Like those monitors are fantastic, but only if you're actually going to listen and make change from the data. Because like even my husband realized, you know, he was a 2 sandwich a day guy. Well, cutting down to 1 sandwich 3 times a week. I mean, now granted it's a man, so grain of salt, right? He took his weight off and stopped those big spikes. And so sometimes it's just subtle little changes.
Yeah.
Like, one thing I see people do all the time is they'll substitute creamer for oat milk. Oat milk notoriously causes huge spikes. And then how you eat your food too, like not only in the example of like the cake, but when you're approaching a plate, if you eat the protein before the carbohydrate is always better for controlling blood sugar. There's been some good studies, and then making sure you're pairing that with a healthy fat. Those are ways to avoid those blood sugar spikes. And so, you know, it's really good data. You just then have to use it. And the other thing is the exercise. You will find that sometimes the way you're exercising, like the HIIT training, or you know, we still got some marathon runners in their 40s, and their blood sugar is going nuts the whole time. And so that's when it's time to reevaluate.
And speaking of exercise on that point too, is, you know, perhaps when you have those monitors on, and you will find that, okay, maybe like for myself, I wanted a Starbucks cake pop. Well, I had to run up and down my stairs 6 times to get that blood sugar back down. And not because I was like, oh, I want to have one, so I need to run. I had one, saw what it did, and like freaked out. And so I was like doing an experiment, like what does it take to get it back down? And so the data from that is, you know, walking after a meal, or if you're going to have a higher carbohydrate meal, or if you want to have that small piece of cake or cake pop, you know, after you've had your protein meals, you may have to go for a walk, or, you know, on the treadmill or up and down your stairs or whatever, so you don't have the risk factors that sustained elevated blood sugar was going to cause you.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
10-minute walk after a meal can change everything.
Everything.
Yeah.
And then people are then happy because then you can, you know, utilize that glucose for energy. You're not storing it for fat. You'll turn down that pancreas, because if you don't make those changes, today's high insulin is tomorrow's diabetes, because the pancreas can only overproduce insulin for so long, hoping to get glucose into the cells before it just fatigues. And, but here's the thing, like, I'm all about like name changes, but like Rebbecca and I were discussing earlier, everybody's all excited about this new rebranding, or I don't know, I'm cynical, a rebranding of PMOS, right? But what's it going to get us? Is it going to get,
our GLPs? Can we get GLPs now for these women?
Or is it just academia, publishing a paper and going, look, like, but what is it going to mean more funding? Like,
what's the outcome?
Are there protocols? Are we going to find a new way to fix this? Or are we just hoping that maybe insurance will provide more coverage? Like, you know what I'm saying? Like, is it, I don't know.
Yeah.
Is it just a headline? I don't know. I've been studying insulin resistance for years. Like,
is there a hope that endocrinology might get involved? It's a massive endocrine issue. I wish they had taken the word ovary out of it altogether, honestly, because again, it narrows it down to women, which is going to get it less attention.
They will. Yeah, they will. They'll do it that way, right? Because they'll look over all of the other things. They're like, oh, I don't mess with those.
And it leaves out all the inflammatory side of PCOS. Women who have PCOS are usually walking around in a chronic, low-grade inflammatory state. And we see a lot of them who have mast cell activation syndrome too, right? And so the inflammatory part of it has not been mentioned at all, which is a pity. But I don't know what change in the name is going to get us.
Well, and, I think women are still going to be confused about where to go from, because I can tell you 30 years in GYN, you will, if you're trying to get pregnant and you have infertility, GYN will be like, yep, let's get you some metformin. But once you have a pregnancy or are no longer concerned about infertility, then it's like, not us, because GYN doesn't want to deal with metabolic syndrome. They don't want to treat your prediabetes or your weight loss as a general rule. They want to do your annual exams and do your surgery, and deliver your babies. And
I don't think it should be a GYN issue. I think it's been a GYN issue because of the pregnancy issues and because it's got the word ovary in it. But it encompasses every part of our bodies. It should be an endocrinology issue.
I think it should be a team.
True.
Right? I think you kind of, depending on what, like as primary care physicians who are still doing primary care, like we can talk about their lipids and their insulin resistance, and
it has to be a primary care issue.
Yeah. And I think we can definitely pull endocrine in there as well. And if we need to pull GYN for some of the fertility, aspects of that, if the other, but we can't dump it all on the PCP either, because Lord knows there's not many of us in the future, and many of us are
Bolton. You know where it lands every day in each one of our private telemedicine clinics, because we're looking at everything for the next 40 years. And I don't know about you guys, but most of my patients, PCPs, have not addressed.
They're burnout. No, they're burnout. They have too much other crap. I get it. I get it for sure. A team is super important still. Progesterone needs to be a conversation. Metformin needs to be a conversation. Their blood pressure, their cholesterol, all the things, right?
Exactly. All the things. It's complex.
It is.
That's why you need a certified menopause practitioner, because all of these things take time.
A lot of time. Yeah.
Time. Yeah. It's a journey.
You guys like to cycle progesterone on these patients?
I don't like to cycle progesterone on any patients.
Me neither.
Well, maybe not in a midlife. Actually, I have some. I do have several of my patients that love to cycle their progesterone that are still cycling, though. They're not postmenopausal, and they're not late perimenopause. So they do like it.
I'm so anti-period.
Yeah, a lot of women still like to have their period. It's interesting. But, in these PCOSers, right? These PCOS women who are young and perhaps maybe not even midlife yet, if late 20s, whatever, 30s.
Well, I think for some women who we put on the nightly progesterone as well, we get some bleeding, spotting of sometimes. So sometimes it can be helpful to go back to the cyclic progesterone. Yeah. So
They're
that
not
they
spotting
have a
through there.
bleed. Yeah.
Yeah.
But
yeah, I think there's more than one way to do it, right? I mean, that's the cool thing about medicine and what we do too. There's so many like little nuances and different ways that are all correct, just different, you know.
Ways. And I think it's what you're like, what you've experienced too. Like I don't find that progesterone I haven't found that to be that progesterone causes irregular bleeding. I find that progesterone doesn't do much to periods. Periods are what they are, except when I get up to the 200, that's when I'll start to see people saying at least they're lighter or shorter.
Oh yeah. Especially those women who you can tell have not had progesterone since their late 30s. And they've got clotting and heavy bleeding and cramping. And then you get them on the 200 a night and they're like, I had a normal cycle. Oh my God.
Yeah. That's why I'm such a fan of progesterone. But like, even like I wished like back in the day that I used more progesterone when I was taking care of those young reproductive women who were having headaches or not sleeping or their periods were all over the place. But, you know, and let them, you know, use a barrier method or an IUD or something different for their contraception. I wonder how many people, you know, that you didn't really need to shut down their periods. You just needed to support
with the progesterone. Yeah. Yep. And I usually let them decide daily or cyclically. Sometimes I give them both scenarios, and those younger patients,
they like it.
Yeah.
All right.
I have a little summary here of, you know, treatment, things to think about in treatment. So treatment depends on goals, symptom control, fertility, metabolic health, hair and acne concerns, and cycle regulation. And so common approaches include exercise, especially resistance training, right, girls? Like progressive strengthening in the gym, because the more muscle you have, the less insulin resistant you're going to be. Adequate protein and fiber intake, sleep optimization, stress reduction, insulin sensitizing medications like metformin, hormonal contraception, that birth control pill can be so helpful, spironolactone for your excess hair growth and oily skin. And the GLP-1 medications are showing so much promise for women with PCOS, and then fertility treatments when needed. So there's not one single answer for everybody. It depends on what symptoms you're having. And then we can choose from those. But really, especially the resistance training goes for everybody, doesn't it?
Yep.
Absolutely.
All right. So let's bring this bad boy home. So PCOS, or Polycystic Ovarian Syndrome, is now Polyendocrine Metabolic Ovarian Syndrome, PMOS. If you have this diagnosis or you think you might, this is your invitation to ask for more comprehensive care, not just reproductive care, endocrine care, metabolic care, lifelong care.
We will link to the full Lancet paper in the show notes, along with some plain language resources if you want to dig deeper into what PMOS or PMOS, I can't wait to hear what we call it, actually means for your health. And if this episode helped something click for you, or if you know someone who may be sitting with a confusing PCOS diagnosis and not quite knowing what to do with it, please send all of this information to them.
This is exactly the kind of conversation we started this show to have. Thanks for being with us. If you enjoyed this episode, like and share it with someone you care about, leave us a review, and we'll see you next time on the Dusty Muffins.
Bye, everyone.
Bye.
Bye.